you would then have to take a huge amount orally to get the same dose as injection. And then I think that, as I understand it, that makes it not so feasible. So no, my understanding is that these are rather complementary treatments in a way, that there are a certain number of patients who won't inject for whatever reason, and that oral GLP-1s can be an option for them, but no, that it's not to kind of replace, because I think it's just not. With the nature of the drugs anyway as they are, then it's not going to happen. But they're more complementary. But I think it's an interesting area. I mean, obviously, compliance of oral products is so much higher that it's interesting.
Very good, very useful. So how do you win in this market, right? So what's pharma looking for when they evaluate a product from HCL vis-a-vis Owen or Meridian, right? What we call in my jargon the key purchase criteria. Do you have any sense for auto-injectors? What are those?
Yeah, well, yes. Again, it's not such a straightforward answer.
I'm sure.
No, but as we touched on, the therapeutic areas of the product here are so varied. The requirements for the product can be quite different in different areas. So for example, if a pharma company has a new drug, as a kind of new class of drug in a therapeutic area where there is not really any good treatment, then kind of any old device will do, as long as they can have it quickly. And then companies, well, SHL and others offer off-the-shelf type devices, which kind of have minimal opportunity to customize or make bespoke for the target patient group, but they can be done quickly. So they're maybe not the optimum or the best product, but you have it quick, and of course then that can be that can be really effective. And I think Trulicity might be an example there. It's maybe not the best device, but it's not really any auto-injectors in that therapy area today. So it can be fantastically successful for patients and just giving them what they want, compared to if they were injecting with a pen injector before. So, but if on the other hand you're sitting there with a new rheumatoid arthritis drug, for example, looking to come into that market, there's already a large number of auto-injectors in that space, then you probably, unless your drug is sitting there with a huge advantage over the other therapies, then you look for some differentiation probably then in your device, and you'll be looking for maybe extra features or extra design of that device that can really be attractive to the patient, to make them want to prefer to use that, or I guess give an advantage maybe in terms of cost that can be a differentiator then in terms of reimbursement or for the payer. But you'll need something then that can, I guess, help you differentiate against the competition, which will be quite well developed. And so you see, I guess it depends what sort of area you need to compete in as to what the requirements of the device are.
Yep.
If you have a generic drug, cost might be everything, so you just want the cheapest the better. And on the other hand, if it's a really high value, low volume drug, then maybe you've got a bigger budget. Cost isn't such an issue, and you can spend a little bit more on features and making the thing nice. So it can be really different. And sorry, I'm rattling on now. But another example is if it's an emergency device like epinephrine or something like that, then their reliability becomes the absolute essential requirement, and you need the device. Not that they're unreliable anyway, but that you need extra levels of robustness and security of the device to function. So. You need again maybe a slightly different feature set to bring a product in that area. So so it all depends.
Got it. Thank you. Let me switch a little bit of topic for a second, right? Do you see,